covered stroke volume and cardiac output, we now are going to move forward and talk about mean arterial pressure. When we look at our Wigger's diagram, we had identified the arterial pressure by this line here. And we said systole was that part of the cardiac cycle where the ventricle was contracting. So what we've identified here is what we call the systolic pressure. So this is the maximum pressure in the aorta during the cardiac cycle. So here we show this as being about 120 millimeters of mercury. Diastolic pressure is the lowest pressure in the aorta during the cardiac cycle, and we'll notice that that's going to be at this level, which will be about 80 millimeters of mercury. So typically when you go to the doctor and you get the blood pressure checked, you'll typically see the blood pressure recorded as in this fashion, which would be 120 over 80. So that's the systolic pressure over the diastolic pressure. And that's a commonly used number, and that's a number which many medical therapeutics are going to be directed at. When we're talking about physiology, and a number that's oftentimes used more in critical care type settings is a number called mean arterial pressure. So the mean arterial pressure is the mean pressure over the entire cardiac cycle. So recall that if we look at these different phases of the cardiac cycle, here we have systole, and then the purple represents diastole. So we actually spend more time in diastole than systole. So the mean pressure is going to account for this. So the way this is calculated is by taking the diastolic blood pressure and then adding to that 1/3 the difference between systolic minus diastolic. Now we are not going to be calculating mean arterial pressure in this class. That's a simple and unnecessary process to do. But just realize that if we take the numbers of 120 over 80 and plug them into this formula, we would get a mean arterial pressure somewhere around 90 or 93. Now the mean arterial pressure is the driving force of blood to tissues. This is the pressure that's basically present in our arteries at all times, pushing blood out to the body. Now, a formula which can help us understand mean arterial pressure is given here. And this is a formula which you need to ingrain into your brain and understand these relationships, because this is the basis of cardiovascular physiology, and understanding this is necessary in order to understand the cardiovascular system and eventually treating cardiovascular disease. So the formula is mean arterial pressure is stroke volume times heart rate times SVR. Now this is not a formula which is meant to be plugging numbers into. This is a formula which is about relationships, and that's how we're going to address this as we move forward. So we've already talked about stroke volume and heart rate. So now we need to define SVR, or systemic vascular resistance. So systemic vascular resistance, another term you'll hear used for this is a term called afterload. So afterload and systemic vascular resistance are exactly the same thing. The term afterload is kind of nice in that it gives a picture that systemic vascular resistance is the load after the heart. So it's the load that the heart's having to work against. Systemic vascular resistance is the resistance that the heart is having to work against to pump blood out to the body. So the primary site of resistance is our resistance vessels, the arterioles. Okay. So as we talk about changing systemic vascular resistance, physiologically, it's often dealing with changing the vascular smooth muscle in the arterioles. But in addition to the arterioles, SVR can also be affected by the outflow tract valves, or the aortic or pulmonary valve. So this is a picture showing the aortic valve opened It's a 3-leafed valve typically, and when the ventricle contracts, these leaflets typically push back up against the edge of the aorta, and so it provides very little resistance to blood flow. But as cardiovascular disease sets in, and these leaflets become scarred and narrowed, or this is a condition which is not actually an unusual condition, where people are born with what we call a bicuspid aortic valve, where they have 2 leaflets instead of 3, and these patients are much more likely to develop scarring. So imagine as blood is being pumped from the left ventricle, much easier to leave through this wide opening than this narrowed opening. So this would create a significant increase in resistance. Okay. Now what we're primarily going to be focusing on in our class is the effect of the arterioles affecting afterload. Now, as we talk about systemic vascular resistance, I do want you to understand the relationship that systemic vascular resistance may have on stroke volume. So in this illustration, think of the heart, the hand squeezing the heart, as representing the contractile force of the heart. So we have 3 different scenarios, all of which we're having the same degree of contraction on the heart. Afterload is the resistance the heart is having to pump against. So if this is our baseline systemic vascular resistance, this is the resistance the heart is having to work against to get blood out to the body, this is going to give us a certain level of stroke volume. What happens if we reduce systemic vascular resistance? Well, reducing systemic vascular resistance means that we are making this opening wider, correct? So even though this is larger than this picture, what I'm trying to depict here is that we actually have a wider opening, and therefore we're reducing the resistance the heart is having to work against. So if we're reducing the work the heart has to work against, or the resistance the heart has to work against, then with the same force of contraction, we would expect to see a greater amount of blood flow going through. So reducing SVR is a way that we can increase stroke volume. And on the other side, if we increased SVR, meaning we're increasing the resistance the heart is having to work against, we would expect that to cause a decrease in stroke volume. So this is a relationship you need to understand, that there is a direct relationship between systemic vascular resistance and stroke volume. Now, having said that, I want to come back to our formula of mean arterial pressure is stroke volume times heart rate times SVR. So each of these variables on the right can change independently, and one may go up and another go down, and that's where things can get quite confusing as far as trying to predict what the mean arterial pressure would be. At this stage, I want you to learn the direct effect on mean arterial pressure that results from an isolated change in one of these variables. So I'm trying to make this as straightforward and easy as I can for you. So this is what I want you to think. If I tell you that we do something to increase the stroke volume, you should immediately think that then is going to increase blood pressure. If we do something to increase heart rate, that will increase blood pressure. And if we do something to increase SVR, that also is going to tend to make us increase blood pressure. Okay. So if we can get you to get those direct effects down, then as you continue along in your medical career, we can then have a better understanding of how complex these different variables can be as far as impacting mean arterial pressure. But right now, I want you to stick with the direct effects of changing these and the effect it would have on mean arterial pressure. So some of you are already looking ahead and thinking, well, you seem to have just contradicted yourself in the last few slides. And so I want to address that. So I had said that if we change or increase systemic vascular resistance, that is going to increase mean arterial pressure. Or if we decrease systemic vascular resistance, that's going to decrease mean arterial pressure. But then I also explained how SVR can affect stroke volume. So I want to talk about that here. So we said that if we increase systemic vascular resistance, that would lead to a decrease in stroke volume. Well, if we look at our formula and we said a decrease in stroke volume then would cause a decrease in mean arterial pressure. So if we use the transitive property of mathematics or logic, we would then seem to suggest that an increase in SVR would actually lead to a decrease in mean arterial pressure. But that's not the case, okay? Not in a healthy heart. Okay? So an increase in SVR will lead to an increase in mean arterial pressure. Changes in SVR, changes in afterload have a greater impact on mean arterial pressure than the effect it has on stroke volume. Okay. So I go back to my point. If I tell you you have an increase in SVR, you immediately say that will tend to make pressure go up. If we move in the opposite direction, a decrease in SVR. Okay. Now I've said a decrease in SVR would decrease mean arterial pressure. But we also have stated that a decrease in SVR would increase stroke volume. And if we increase stroke volume, that would increase pressure. So I seem to be talking out of both sides of my mouth here. Again, the transitive property then would suggest that a decrease in SVR by increasing stroke volume would actually cause an increase in pressure. But again, no. A decrease in SVR is going to cause a decrease in mean arterial pressure because the changes in SVR have a greater impact on mean arterial pressure than they do on stroke volume. So changes in SVR directly correlate with changes in mean arterial pressure. All of these factors here directly correlate with changes in this number here. An increase in any of these causes an increase in mean arterial pressure. A decrease in any of these is going to tend to cause a decrease in mean arterial pressure. So if we look at mean arterial pressure and the various factors that are involved with it, we then are going to have to come back to, well, how can we control mean arterial pressure? So this is a slide which is actually going to be basically a review slide. This is no new information on this, but this just puts on one slide the various factors that go into our body's ability to maintain mean arterial pressure. The only two systems we have to work with are our parasympathetics and our sympathetics with regards to us controlling mean arterial pressure. So we said parasympathetics go to the SA-NAV node and they decrease heart rate. Decreasing heart rate would decrease cardiac output, and that would cause a decline in mean arterial pressure. Sympathetics also go to the SA-NAV node and they increase heart rate. By increasing heart rate, we increase cardiac output, we increase mean arterial pressure. Sympathetics go to the ventricular muscle. The ventricular muscle, they cause an increase in contractility, which causes an increase in stroke volume, which would be an increase in cardiac output, which would be an increase in mean arterial pressure. Sympathetics go to arterioles. They cause vasoconstriction when we stimulate them. Vasoconstriction increases SVR. If we increase SVR, we increase mean arterial pressure. And sympathetics go to veins. When we sympathetically stimulate veins, we vasoconstrict the veins. We decrease their compliance. We decrease their capacitance. That causes an increase in venous return, which is going to result in an increased stroke volume, which is going to result in an increase in mean arterial pressure. So it's the interplay between these various responses that the sympathetic and parasympathetics can bring about is how we regulate our mean arterial pressure. Now, something which I want to highlight here is notice that the parasympathetic only affect heart rate. So everything else is going to be controlled by the sympathetic system. Mean arterial pressure is that force which is driving blood throughout our body to provide for its metabolic needs. So with the idea of homeostasis, blood pressure is certainly going to be one of those factors that we need to keep tightly regulated. So in regulating blood pressure, this means that we're going to need to have some types of sensors that are going to help us inform our body whether or not our blood pressure is appropriate or not. And these are called baroreceptors. There's baroreceptors throughout our body, but the most important ones which we're going to focus on for our discussion are located in the aortic arch and in the bifurcation of the carotid, and these are called our aortic and carotid baroreceptors. These are going to be sensing pressure changes within our arterial system, and they then will be sending that information to the cardiovascular control center, which is located in the medulla of the central nervous system. The cardiovascular control center is the integrating center, which is going to be taking this information, and if our mean arterial pressure is not in the proper range of where it should be, it will then send out signals to bring about changes to get it back where it belongs. The method by which it will do that will be through our autonomic nervous system. So we will have sympathetic as well as parasympathetic nerves being directed by the cardiovascular control center to bring about appropriate changes. So recall that our sympathetics go to the heart, they go to the SA node, the AV node, and ventricular muscle. They work on beta-1 receptors. Our parasympathetics go to the pacemaker cells and work on muscarinic receptors. Here we show the ventricular muscle also innervated by beta-1 receptors of the sympathetics. Sympathetics go to our arterioles as well as to our veins, also working on alpha receptors. So if we have a drop in mean arterial pressure, which is picked up by the baroreceptors, a signal will then be sent to the cardiovascular control center, and the cardiovascular control center is going to give an immediate response, and its response is going to be to increase sympathetic activity and decrease parasympathetic activity. If we have an increase in mean arterial pressure, the cardiovascular control center is going to do the opposite. It's going to decrease sympathetic activity and increase parasympathetic activity. So let's look at each of these a little bit more specifically. And the way that we think about these things is always going to be, what is our body's response to a drop in blood pressure? Okay. So if we have a drop in blood pressure, what will the response be? So a drop in blood pressure will be picked up by the baroreceptors. The cardiovascular control center, sensing this drop in blood pressure, is then going to send out its signals via the autonomic nervous system. It's going to be an increase in sympathetic output, and that's going to be to the SA node, which is going to cause an increase in heart rate, and that's going to be beta-1 receptors. Remember, those beta-1 receptors on those autorhythmic cells will cause an increase in the sodium funny channels, which increases the pacemaker potential, which will increase heart rate. If we increase heart rate, that's going to tend to bring our blood pressure back to normal. We'll also have sympathetic stimulation on the ventricle, again, beta-1 receptors. This is going to be an increase in contractility, increases ejection fraction, which is an increase in stroke volume. An increase in stroke volume is going to work to try and get our blood pressure back up to normal. We have our sympathetics working on our arterioles. Those are alpha receptors. We stimulate those. That causes vasoconstriction, which is an increase in systemic vascular resistance. An increase in systemic vascular resistance will work to try and increase our blood pressure. Veins also will be sympathetically stimulated. These will This vasoconstriction of the veins will decrease the compliance of the veins or decrease the capacitance of the veins, which means that the blood that the veins were holding on to will now be forced back to the heart, so we'll be increasing venous return. That will result in an increase in stroke volume by the Frank-Starling mechanism. We'll also see our parasympathetic system adjusted. In this case, because our blood pressure is dropped, the parasympathetic system will be turned down, and that will cause an increase in heart rate. Let's work through the opposite. What if we have an increase in blood pressure? The response to this would be that we will turn down our sympathetic output. So by turning down the sympathetic output, we're going to be decreasing the heart rate. By decreasing sympathetic stimulation of the ventricle, we'll be decreasing contractility, thereby decreasing ejection fraction, decreasing stroke volume. We will turn down sympathetic stimulation of arterioles, therefore we will be vasodilating those arterioles, which will decrease SVR. Same thing occurs in the veins. We decrease sympathetic stimulation of the veins, which results in vasodilation of the veins, which means the veins become more compliant. They have a higher capacitance, so they will be holding on to blood, which means they'll be decreasing venous return, which will cause a decrease in stroke volume. Our parasympathetic system will increase its activity, and it will have its primary effect by decreasing heart rate by bringing about these changes in the autorhythmic cells.